Okay, so let's get started. So first, I'd like to welcome everybody to the last PanAmerican Hemodynamics Collaborative webinar of the year. My name's Laura, and I run the administrative operations for the Neonatal Hemodynamics Research Center. Just a couple points. The talk is being recorded, and I will post it on our YouTube channel in about a day or so, and I can put the link to our YouTube channel below. Further, please type your questions for our speaker and our panelists in the Q&A box, not the chat box, and then those will be answered in the moderated session after the main event. And so with that, it's my pleasure to first introduce our moderators for today's session. Dr. Daniel Rios is an associate professor in the Division of Neonatology at the University of Iowa and associate director of the Neonatal Hemodynamics Fellowship Program in Iowa. And joining her today to co-moderate is Dr. Joseph Ting. He's an associate professor in the Division of Neonatal and Perinatal Care at the University of Alberta and staff neonatologist at Stollery Children's Hospital. And with that, I pass it on to the two of you.
Okay, thanks very much, Laura. So it's my great pleasure and honor to introduce our speakers and also the panelists. And we are very fortunate to have Dr. Willem de Boode to talk to us today. And he is the professor of the neonatologist at Radboud University, and he's also the elected, he has also been elected as the president of the European Society for Pediatric Research. And he is the pediatric neonatologist at the Amalia Children's Hospital, Nijmegen, and he's very well known for his excellent research work in the neonatal hemodynamics, and he has been the chairman of the ESPR Special Interest Group Neonatologists Perform Echocardiography, which is formulating European clinical, technical, and training guidelines regarding the use of the echocardiography. And most of you probably know that he's also the lead in an international multi-center randomized non-inferiority trial of early treatment versus expected management of PDA in preterm infants. He's going to talk about the non-invasive monitoring today, and we are also very fortunate to have three experts to be our panelists. One is Dr. Valerie Chock, who is the Associate Professor of Pediatrics at Stanford University. He has been well known for she has been well known for her near-infrared spectroscopy clinical monitoring research. Dr. Vasilis is an assistant professor at the Washington University. His expertise is in the computational monitoring of high-resolution multimodal physiology to eliminate the mechanisms of brain injury in the infants. Dr. Eugene Dempsey is a professor and neonatologist at Cork University in Dublin. He has been well known for a lot of research work in the neonatal hemodynamics, and he's also an active member of a number of international organizations like ESPR, European Neonatal Echo Working Group, as well as the European NEARS Working Group as well. And without further delay, I will pass the stage to Dr. Willem de Boode. Please be reminded, if you have any question, please put it in the Q&A, not the chat box, and we are going to have a section on the Q&A after the lecture. Thanks very much, Dr. de Boode.
Well, thank you so much for this nice introduction, and thank you for inviting me to speak in this webinar. And I'm very happy to present on the non-invasive monitoring in hemodynamics. Let me first be sure that I got a good pointer. First, I would like to disclose that our research group has received research grants or equipment has been put to our disposal by these firms, but I would like to let you know that there's no financial relationships at all. The outline of this presentation is that after the introduction, I will speak about validation of hemodynamic monitoring. I will talk about methods of non-invasive cardiac output monitoring and emphasis on the three technologies described over here. Then we'll get back to validation. I will explain why it's separated in two. And then after the summary, I will try to make a conclusion. We all know that there is a oxygen balance, and in a normal situation, the oxygen delivery is far higher than the oxygen demand. And what we would like to prevent is a state of shock in which the oxygen demand is much larger than the oxygen delivery. But to be informed about that, we have to know what is the oxygen delivery to the body. And we can see the delivery because that's determined by first the hemoglobin concentration. It's also determined by the oxygen saturation of the blood, by the cardiac output, and to a lesser extent to the partial pressure of oxygen. And we're all very familiar with measuring hemoglobin, oxygen saturation, and partial oxygen pressure in the blood gas analysis. However, cardiac output is not that regularly performed or routinely being measured. And as you already noticed, I'm talking about the oxygen balance, and my focus on this presentation will be on the macro circulation, so the systemic blood flow, cardiac output. It's not on organ level because that's also possible. It's, for example, the perfusion and oxygenation of the brain with near-infrared spectroscopy. But you can also focus on the microcirculation, even going further on cellular level or on the mitochondrial level. And as said, for this presentation, I will focus on the macrocirculation. Well, if we want to measure cardiac output, can that be done? There are different several techniques out there that enables us to measure cardiac output in critically ill patients. However, to do that in newborns, and especially preterm newborns, that's very complicated. And that's related to the size restraints. And as you can see over here on the left side, bottom side, there's a transesophageal probe. It's as large as the forearm of a baby. And of course, you can understand that's not possible. On the right, you see a pulmonary artery catheter, the Swan-Ganz catheter. It's obvious that can't be used in a preterm infants. But another problem is the presence of shunts. A lot of technologies cannot be used in the presence of shunts. And in our patient populations, there's a high incidence of shunts through the ductus arteriosus or foramen ovale. So that means a lot of technologies are not feasible in newborn infants. And the last restriction is the indicator toxicity. A very nice technology to measure cardiac output is the carbon dioxide rebreathing technology. And then when you've got a patient on the ventilator, in the ventilatory circuit, you can make a sort of bypass. And with that, you can increase the carbon dioxide, and the change in carbon dioxide that can be measured is related to cardiac output. But as we all know, what we don't like in preterm infants to have a fluctuating arterial partial pressure of carbon dioxide, because that's related to the cerebral perfusion. And that's why we would like to avoid any fluctuations in carbon dioxide. Another possible technology is the indicator dilution method. It's the lithium dilution method, but that requires the injection of a small amount of lithium as an indicator. And everyone can understand that's not what I would like to do in a preterm infant. So that means that not all technologies are feasible in newborn infants. That brings me to a validation. If we look at a possible or potential technology we would like to use for hemodynamic monitoring, I think we should pay attention to validation. And any new technology should be compared with a gold standard reference method. And that reference method should be accurate, with a small variability, reproducible, and not be influenced on the method that is studied. And what we consider the gold standard reference method in the animal experiments are the transit time flow probes around the main pulmonary artery. And in clinical pediatric studies, the FIC technology or the transpulmonary thermodilution are considered as such. And the last one is also known as the PICO method. And in clinical neonatal studies, it's the cardiac MRI, the transthoracic echocardiography, or the transpulmonary ultrasound dilution, the CO status. If we want to know about the accuracy and the precision, I would like to explain something about the blend element analysis. And in this, on the x-axis, you have the mean between the two methods. You have method A that is compared to method B, and you want to see whether they are in agreement or not. On the x-axis, you take the mean of the two methods, and on the y-axis, you have the difference between the two. And in this is a situation, you have all the different measurements, simultaneous measurements with method A and B, and this is what you can have a scatter plot. Then you can measure the mean difference. It's called the bias, and that's defined as the mean difference between the new method and the reference method, and that represents the systematic error. But you can also determine the limits of agreement, the upper and the lower limit of agreement. And the limit of agreement is determined, can be calculated as 1.69 times the standard, the standard deviation. And you can say the precision is represented by the limits of agreement, and 95% of all the measured values are positions between these limits of agreement. So you can have an absolute value, but I think it's very valuable to express it as a percentage of the mean cardiac output instead of only an absolute value. And so you can measure the mean bias. And if you divide that by the mean cardiac output times 100%, that's how you express the accuracy in bias percentage. On the other side, the precision, you can express it as error percentage. That's the limit of agreement divided by the mean cardiac output times 100%. And this is how I would like to explain. On the x-axis, there's the accuracy. And so it's the bias percentage. So the more to the right, the more closer to bullseyes, that represents the real true value, the measurement is. So, and on the y-axis, you see the precision, the error percentage, and that is telling you something about the spread of the data. And the higher on the y-axis, the more close every measurement is in the same region. So what you can see on the left bottom panel, it's just a random try to get the good value. It's not very worthwhile. On the right upper, that's the ideal situation. Every time you hit bullseye, so that is an ideal situation. If you see the right lower panel, there is a technology that you will have to do a lot of measurements and average them, and then probably you have a good way of a good estimation of the true value, the true value of the cardiac output. Also, the left upper panel is interesting because there's consistently the same measurement, but it's not the true value, but there seems to be a set off, and that what you can correct for. So this could also be a very interesting technology. In January, a new technology is accepted when the error percentage is less than 30%. And that is in the assumption that the precision of the reference method is around 10 to 20%, and that the acceptance of the new technology is in the same range, that will say it's also less than 20%. So for the reference method with an error, if you've got a reference method with its own error percentage larger than 20%, you have to adjust that cutoff value of 30% for acceptance. And for that, you can use the errorgram. And as it's being put out in this errorgram, here you can see the error percentage of the comparator, so the tested method. This is the reference method. So if we see, if you want to have the red one is the 20%, and if the 20% you get, you see that 20% for both methods, it will give you the 28.3%. So that's why for a clinical situation, 30% is regarded as acceptable for the error percentage. But as said, if your reference method is not that good, you have to adjust that acceptable range. Let's go back to cardiac output monitoring. What are the different technologies? Well, you've got technologies, a method that are based on the Fick principle, either the oxygen or the carbon dioxide Fick method, the indicator dilution technologies, the Doppler ultrasound technologies, the electrical biosensing technology, arterial pulse contour analysis, and the cardiac MRI. And if we focus on those technologies that are feasible in newborn infants, then these are the ones that can be used. Transthoracic echocardiography, transcutaneous Doppler, transpulmonary ultrasound dilution, electrical biosensing technology, and the pressure recording analytical method. It's the pulse contour analysis of the arterial blood pressure. But if we look and we want to focus on non-invasive, then the transpulmonary ultrasound dilution cannot be considered non-invasive because you need both a central venous line and an intra-arterial line. And for the arterial pulse contour analysis, you of course need an intra-arterial line. So let's discuss the non-invasive technologies for cardiac output monitoring. And if we look at what the industry is telling us, we can look at different forms. For example, the electrical cardiometry, the electrical biosensing, the window to circulation. The USCOM, I will talk about it, it's a transcutaneous Doppler. This machine is saving lives. And the Baxter, it's the NICOM. The new version is called the Starling SV. That was the NICOM by Cheetah, and that has been taken over by Baxter. It's offering a fully non-invasive and highly precise approach. So let's dig into that. The most used method of measuring cardiac output is the transthoracic echocardiography, the neonatologist performed echocardiography, or the TNE, whatever you would like to use. It has been introduced by our Australian colleagues, and it's increasingly being used. I don't have to explain that. What we know is that the intra-observer variability is around 10%, and the inter-observer variability around 15 to 20%. And how does that work? You need a Doppler measurement of the blood velocity in one of the outflow tracts. You can measure the velocity time waveform, and you track that and take the area under the curve. And with that, you will have the stroke distance, because it's the velocity in meter per second in time in seconds. So you will get an distance. So that what you get is the distance that a column of blood will travel during one heart cycle. What you then need is the cross-sectional area of the outflow tract you're measuring. And with that, you can construct a stroke volume. You have a tube, and the content is the stroke volume. And in that way, you can measure the cardiac output, because if you got stroke volume and you got heart rate, in that way you can measure blood flow. You can express it in milliliters per minute, or express it and index it to body weight in milliliter per minute per kilogram. There are some pitfalls, because it's very difficult to assess the real outflow diameter. And the outflow tract is not a static and ideal round-shaped vessel, but it can be, for example, if you have the SVC, or the inflow of the heart, so it's not cardiac output, but partial cardiac input, that's influenced by the aorta that's adjacent to it and is pulsatile. Also, the blood flow is usually not laminar at the place you're measuring. And we're measuring the VTI in the center of the vessel with the highest velocity. Moreover, it's very important to have a true measurement that the angle of inclination is less than 20%. And moreover, there's a complicating factor that there's a cardiorespiratory interaction. So there's a change in the velocity time integrals. So you have to average that over 3 to 5 heart cycles. And this is the way it's being done. You measure the diameter of the outflow tract, and you get a velocity time integral, and with that you can measure and have a milliliter per kilogram per minute in cardiac output. For this instance, it's the left ventricular output. But you should also take into account that you're measuring cardiac output, but be aware, where am I measuring? Are you measuring the left ventricle output, the right ventricle output, descending aorta? Is it the vena cava superior flow? Because it's important whether or not there's a shunt. If you have the left ventricle output in the presence of a left to right ductal shunt with a high shunt volume, you will have a overestimation of the systemic blood flow, because then the left ventricle output that you measure is the systemic blood flow increased by the transductal flow. So it's always important to know with the echocardiography where I'm measuring, are there shunts? But that's also the advantage of the echocardiographic assessment, that you got a true side of the circulation. You get information about potential shunts. If we look at a review regarding the Doppler cardiac output measurements in children, and that and they had for the reference method reliable method, dye dilution, thick or thermodilution technologies, you can see the bias is less than 10%, but the precision, be aware, is plus minus 30%. I was surprised by that. So it's not as precise as we thought it was. And as already mentioned, why is that? Because of the problems with the angle of inclination, difficulty in the VTI assessment, and the error in the cross-sectional area measurement. If we look at data about validating these transthoracic echocardiography, it's very difficult to find that. There are no data regarding the right ventricular output. There is for the left ventricular output, and that's with the reference method, the phase contrast MRI. That's a really reliable method. And you can see, and indeed, it's around a 30% error percentage. And it depends for the SVC flow, whether or not what kind of method you use for the diameter. If you and you can go up to or error percentage of 70% with measuring the SVC area instead of the diameter. It's causing less miscalculation. So, but be aware also with the transthoracic echocardiography, it's not a very accurate or precise method. Then let's go to the transcutaneous echocardiography. It's the ASCAM. And with that, you assess the cardiac output with a non-invasive ultrasound probe positioned at either the sternal notch, and you're trying to aim at the aortic valve. So you're not seeing the valve, you're trying to get the best flow patterns. So it's a visual inspection of the quality of the velocity velocity graphs, or you aim at the pulmonary valve. So as you can imagine, if you have it inside with the transthoracic echocardiography, it's not that, you have an error percentage of 30%. If you try to aim and only look at the velocity figures, it must be very difficult. Also, the cross-sectional area is not measured. It's derived from an algorithm using the height, the weight, and the age of the patient. So if we look at a meta-analysis of the accuracy and the precision of this transcutaneous echocardiography, you see that the error percentage is 42%. So not that precise, as I would expect. Let's focus on the studies that looked at children and neonates. You even see much worse percentage for error percentage, up to 65%. I don't think that's strange, because it's just aiming and trying to get a good signal as possible. I think we should be aware that probably this is a very feasible method, easy to be done, however, not accurate and not precise. Let's move to the electrical biosensing technology. It's non-invasive, easy to apply. The first study was presented and published in 1949 by the Russians. The first, I thought it was by NASA, but when during a talk in Russia, they told me that I was wrong, and they were right. And it showed me how biased I am by only looking at the Anglo-Saxon literature. But they showed me that the Russians were first. In this technology, we have the transthoracic bioimpedance, the ICON or the Escalon, the transthoracic bioreactance, the NICOM, or nowadays the Starling SV, or the whole body bioimpedance is the NICOS. And in this technology, there you use the fact that electrical conductivity of blood is higher than that of fat, muscle, and air. And if you apply a high frequency, a very low magnitude current across the chest via electrodes, that distributes mainly to the blood. And you can calculate the bioimpedance as the ratio between the measured voltage and the applied current. And if the current is of a constant amplitude, there's a direct relation between the measured voltage and the impedance. So pulsatile changes in the thoracic blood volume will cause changes in the thoracic electrical impedance, and that is proportional to stroke volume. And it is thought that the reduced impedance during the systole is caused by an increased blood volume, increased flow velocity, and alignment of the red blood cells. And if we compare bioimpedance versus bioreactance, you have the measurement of the change in bioimpedance. Then the bioresistance, you look at the magnitude, the difference in magnitude, and with the bioreactance, you look at, so this is the input and this is the output. The change in amplitude is measured in the bioresistance, while the change in phase is what is measured with bioreactance. This is the transthoracic bioimpedance, the ICON. You have electrodes. The patients never look that happy in my unit. And it's thought that during systole, there's an alignment of the red blood cells, which makes more easy for the current to flow. And that's why the bioimpedance is less. And this is for your bioreactance. You can see that there's a shift, and the higher the shift, the higher the stroke volume will probably be. But all these technologies use some kind of algorithm that's not known to us. They don't want to tell, because there's a translation between the change in bioimpedance and try to estimate a stroke volume. Another method is the whole body bioimpedance. So it's not only located on the thorax, but it's a peripheral impedance signal. You have the current applied through the body via two pairs of sensors, one on the wrist and one on the contralateral ankle, and with some kind of correcting factors, unknown factors, they derive stroke volume via the change in impedance. Let's look at the validation studies. And what you can see is transthoracic bioimpedance, transthoracic bioreactance, and you can see that the error percentages do change a lot. And also in this slide, you can see most of them are really over the 30% as accepted for a clinical application. Also, if you look at stroke volume instead of cardiac output, it's a rather high error percentage. So that's when we look at absolute values, but wouldn't it be nice, and that's what we try to do, we don't need to have the absolute values, but if we can use it for the trend monitoring. And that is lacking nowadays in the literature. There's not much data on trend monitoring for these devices. How can we determine the trending ability? Well, we can make a concordance plot. And in this, you have the change of the reference method of cardiac output on the x-axis and the change in the comparator on the y-axis. And of course, if it increases in the reference, it should also increase in the comparator. So you should be in the green zone. But also, if they decrease, they should both decrease. So you want them to be concordant, changes in the same direction. And you can determine the concordance rate, which is the percentage of concordant measurements of the total number of measurements. And we call it the trending ability good if it's over 95%. However, this does not consider the magnitude of the changes in cardiac output, and for that we need the polar plot. And if we have the reference method over here and the comparison method over here, this is the first measurement, this is the second measurement. And what you want is to be them on the line of identity. The change with the one is the same as the change in the other. However, that's not the case. What you can do is to combine this, and you look at the magnitude of change, that's the length of this vector. You can average it, or you can use the hypotenuse and use that as one of the parameters. And you have the angle to the line of identity that's defined as the agreement. And in that way, you can have these polar plots. In an ideal situation, everything is on the line of identity, and everything will be on 0 degrees with a short limits of agreement. What you have if you have a polar plot, you have a mean polar angle or angular bias. That's the average angle between all polar data points and the polar axis, whether positive or negative. The standard deviation, so both are the same as with the Bland-Altman analysis. It's similar to that, and the limits of agreement, but then the radial limits of agreement. And there's a central zone, because there is a zone if there's a minor changes and it is only 0.5% increase versus 0.5% decrease. Probably that's not really important. So the central zone is the area you like to discard. So the good trending ability is when there's a mean polar angle less than 5 degrees with the radial limits of agreement of less than plus minus 30 degrees. So recently, my colleague Liesel van Wijk from South Africa, she looked at that for the bioreactants. So that was the Cheetah NICOM, and looked at the trending ability, and look at it, only 77% of the data points were in the green zone, so concordant. So that's rather disappointing. Angular bias exceeding the 5 degrees, limits of agreement radial exceeding the 30 degrees. So probably it's not as good also in the trending ability. We did at our site, not published yet, we looked at the icon, and we've got the same concordance rate of only 55%, and also the polar plot analysis, very disappointing. And what was striking in these comparison of the icon versus the transthoracic left ventricular output, this is the transthoracic, so the echocardiographic cardiac output versus the cardiac output determined by the icon. And you see a range of echocardiographic cardiac output, but it looks like the icon, everything is within the normal range. Everything is within the normal area. So that's strange. So it's something is with the machine that try to normalize all the data. Also the same for the right ventricular output. This is very nice from one of our colleagues on the panel, from Gene Dempsey. They've looked at the icon, and they looked that you have the algorithm trying to translate the impedance into a stroke volume, that it's very much determined also by the algorithm that uses the length and the weight of the patient. And 1 centimeter length error resulted in a change in stroke volume of 1.8 to 3.6% in preterm, and a 100 gram error in weight resulted in a change in stroke volume of 5 to 7%. So really important. But to be honest, we're comparing all these technologies with transthoracic echocardiography, not the best reference method, with its own 30% error percentage. So maybe this one is not that good and these are perfect, but I'm afraid they are not. And what we have to do is to validate them against real solid reference methods. So what are the ideal characteristics of cardiac output monitoring? Validated against a gold standard reference method, accurate. Well, you got all these ideal characteristics. To be honest, that's utopia. There's no such cardiac output monitoring device. That brings me to the summary. Cardiac output monitoring in neonates, especially preterm neonates, remains challenging despite the availability of many different technologies. Please pay attention to accuracy and precision, as well as to feasibility and safety risks. Non-invasiveness is unfortunately inversely related to accuracy. Hence, there will always be a compromise between these characteristics. Given the disappointing accuracy and precision of non-invasive cardiac output monitors, one should be cautious with the interpretation of the acquired hemodynamic parameters. And I would like to finish with advanced hemodynamic monitoring will not improve outcome. It's the correct interpretation of the estimated variables, if the monitor is correct, precise, and the resultant therapeutic management that may improve outcome after all. I would like to thank you very much for your attention, and I'm happy to answer any questions that might be have raised. Thank you.
Thank you so much for that talk, Dr. de Boode. It was extremely interesting, and I think we'll have a very lively discussion today. So if I can get looks like everybody's back on in the video. So we'll go ahead and start off the discussion. I think let's just kind of open it up. And the first question of what you were talking about with accuracy. So in those studies, how do we know, like, do you have any knowledge of, if you put the probes from the different non-invasive monitoring monitors in, maybe a slightly different place, is that what's going to lead to your inaccuracy? Is there any evaluation of, if you put them on the exact right way, that your accuracy improves?
I think it's very important that you have a correct position of the electrodes, because if there's a change in the distance between the electrodes, that will affect the measurement, and that's one of the problems, because the electrodes, they are not designed specifically for the newborn infants, especially not for the preterm infants. So they're rather large. So everyone is trying to adjust and to adapt. And I think that's one of the problems. But it's also the condition of the patients. If you got a patient with a lot of edema, that will influence also the bioimpedance. If the patient is on high frequency ventilation, that will also influence your measurements. So all these conditions are important to consider if you're if you want to use or are using these type of cardiac output monitors. Yeah.
Any of our panelists have anything to add to that?
Yeah, I can jump in if you wish. I mean, sorry, my kid is giving out in the background, so if you hear some noise, apologies.
That is my greetings.
The paper William alluded to, I think inputting weight and length are things we don't normally necessarily do. I mean, lengthening a 24-weeker in the first minutes, it's not something that is part of our routine management, but it's an important aspect in terms of the algorithm and how it interprets the data, because the size of the baby relates in a sense to the positioning of the electrodes. So I think it is something that we don't actually have any real true understanding of. I mean, I think they give optimal sites to place them, but as William said, I mean, you know, a couple of millimeters can probably make a difference. And the Starling is such a, the electrodes are so problematic in terms of small babies. I mean, we don't put them on for research purposes because they're just too large. And you can cut them and pare them if you will, but they are still very large. And also there's ultimately you end up with 8 electrodes on the baby. So yeah, I think practical issues are really important in terms of understanding the placement of the electrodes and the shortcomings related to it.
My perception is that the manufacturers are considering our patients as small adults because they've got an algorithm from the elder population, and that's using the height and the weight, and they just getting into smaller, and they're trying to adjust it for our specific population, but it can't be right. Of course, there must be a relation between the changes in bioimpedance and the stroke volume. However, it's also depending on a lot of other factors. And I think we have to try to find a way to filter it out so that you solely have the changes in stroke volume related to the changes in bioimpedance. And it can't be I've asked multiple times to different vendors, let me know what is that algorithm, but of course that's all patented and they don't want to share it, but it can't be right. And we've looked with several technicians in it, and also in the formulas they're using that are publicly available, there are errors in it. They can't be right.
I see that.
Could I just ask about people's views on, you know, when we say cardiac output, non-invasive cardiac output devices, and you know, what actually is the icon measuring? You know, is it measuring the left? Is it measuring the right? How does it interpret the alteration that happens in relation to ductal flow on the right ventricular output? So what actually is it measuring? And so we went and asked the company, and they couldn't tell us.
I'm glad they told you the same because I also asked them, and it's very difficult. They were surprised by our questions, and well, and they are saying, of course, it's the aorta because it's aligned according to the aorta. But well, you put the sensors on the thorax, it's the total thorax, so that can't be right. So I think there must be one of the problems in the inaccuracy and imprecision of the technology. Yeah.
I see Patrick came on. Do you want to add to the discussion?
Yeah, Danielle, I have the title of rebel panelist or some sort of thing like that. I just appear from left field. I want to let you, Willem, fantastic talk. Thank you so much for taking the time to share your knowledge with us today. I want to latch on to one comment you made in your summary slide, which I think is incredibly important, in which you said cardiac output or advanced hemodynamic monitoring doesn't tell you how to manage the patients. Okay. And I think this is an important part of the discussion, particularly with Jean and Zach and others. We've learned that blood pressure is not a disease, it's a symptom. Mm-hmm. So what is cardiac output? Is it a disease? Is it a symptom? Or, you know, how does it help us, and why do we want to measure it?
I think we have to change our policy because, of course, I assume this is a selected population that know that blood pressure doesn't tell you the whole story, and for that we have to have a blood pressure together with cardiac output, and with that you are informed about vascular resistance. And I think those two parameters, blood pressure and cardiac output, or systemic blood flow, or whatever you want to have, can tell you what is the underlying pathophysiologic mechanism of problems in your patient, or is there a problem or not? Because you can have a perfectly normal blood pressure with a very low cardiac output, provided your systemic vascular resistance is high. So you will never notice any cardiac output failure if you only rely on the blood pressure. And for that, I'm trying to look to find a technology that enables us to measure cardiac output, preferably non-invasive, preferably continuously, and preferably in a reliable, accurate way. I think that's of major importance, because then you can think about what's causing it and try to have a pathophysiologic perspective, try to influence that with your therapeutic intervention. Is it the vasotone you have to influence with vasopressors, or have to give vasodilators? Do you need to increase contractility? And with that, if you have your therapeutic intervention, you can monitor it. So it's not only, okay, this is the problem, this is how I should treat it. No, it's a dynamic problem, and we can change from a inotropic problem into a vasoconstrictive or vasodilatory problem. So it's a dynamic. So we have to try to figure it out in a temporal way. And that's why I really would like to have a cardiac output monitoring that gives me continuous data. And I was always, I thought, okay, it's no problem. The absolute values aren't accurate, precise. But, well, who minds if the trending is okay? Then if it's low and I'm giving something and it's increasing, I'm probably doing the right thing. But looking at the data, and there are only 2 studies in the newborn population that look at trending ability, they tell me they are not good. It's almost as good as flipping a coin. It's 60% concordance. So it's moving in a direct direction. Only a 60% of the measurements for the icon. I was really disappointed about that. I thought, and then thinking about a lot of research papers that have been published in recent years, they show us a plausible hemodynamic profile of the cardiac output. But how is that? How can I relate that to these imprecise outcome of these validation study? And that's what I don't understand. Are we really seeing the real true hemodynamic profiles of cardiac output that has been, or is it not that accurate? Maybe it's the other way around. So that's why I think we should really be cautious. And that's why I would like to stress, if we got a ruler, we want to know and we want to be sure 1 centimeter is 1 centimeter. And it can't be that in the States, 1 centimeter is different from Europe, from Japan, from Australia. But that's what is happening in our way of using a lot of medical devices. No one pays attention to validation studies. And that's I think, the main take-home message. Please take attention to validation studies. Is my device measuring what I want to know? And if it's measuring what I want to know, is it accurate in it? If I do a repeated measurement, will it give me the same value, or is it dependent? Do I get different values? Because we try to treat our patients based on that, but then we want to have the real value. We want to be informed in the correct way.
Yeah, I just wanted to, I brought that up with great provocation because I worry the neonatal community desperately looks for something that's easy and simple. Okay, and the reality is cardiovascular physiology is not easy and simple. And whether it's looking at blood pressure, cardiac output, or I think you alluded to the dangers of echocardiography done in a very loose and limited way, that can be a dangerous tool. And I think it's very, very important to, whatever we do it very wisely and carefully, which
I fully agree, because a lot of people say, wow, what should I do? Because now I don't understand. And yeah, but sorry, we're handling and we're treating very complex patients. And well, it comes with complexity, and try to simplify it is ignoring a lot of possible errors. And I think that's also not the way to go. So we should be aware of the restrictions of the diagnostics we're using, the therapeutics we're thinking it works in a specific way, but we're not that sure in our specific population. Also differing in different grade of maturity. So it is complex, but yeah, it's the true story.
Yeah.
Valerie. Oh, sorry.
No, I'm really enjoying this discussion, and I think listening to Dr. de Boode's presentation, there are a lot of correlates with NIRS monitoring and how that technology started off as a trend monitor and is still primarily as a trend monitor. But I'm just it's interesting how like the NIRS technology has taken off a lot more in the neonatal population in comparison to some of the like the ICON, for example. And why is that so? You know, are there any correlates or any studies that you know of looking at end organ perfusion with something like technology like NIRS with the cardiac output, the non-invasive cardiac output monitoring? Because it's kind of an interesting idea since they're very similar in what we're looking for.
Yeah, that's a very good question, and I just had a search again, and there are multiple studies that have a simultaneous measurement, non-invasive cardiac output, and the regional oxygen saturation, either the brain or the kidney or the intestinal area. I think it's also for the near infrared spectroscopy. I think that's a very important way of hemodynamic monitoring, but also that is not that precise, to be honest. If you put on the NIRS monitor and the sensor and you put it in another place and you replace it, you will have different values. And we have different monitors, we've got different sensors, they're not telling exactly the same. So the limits you use as well, this is really hypoxia regional. In one monitor with the sensor is 55%, and the other is 65%. So you have to be aware of the limitations of your specific device and sensors that you are using. I think it's of major value, the NIRS monitoring, especially for the brain, because that's what we want to prevent, to have cerebral hypoperfusion of hyperperfusion, hypoxia or hyperoxia. However, in my perception, still, I would like to have that as part of a comprehensive hemodynamic monitoring system. But what I see is a lot of centers are only using the NIRS. I think that's a pity, because you're waiting for a relatively late sign. Why wait for the problem in the brain to act? I would like to detect earlier to try to prevent a hyperoxia or a hypoxia in the brain. So it can't be only the NIRS. It should be part of a comprehensive hemodynamic monitoring. Yeah.
Zach, I think you were going to say something, and then I see Jean, you have a comment.
Sure. Yeah, there were two different things sort of building on both of those points. Something that I worry gets lost a lot in the hemodynamic monitoring is that it's both a problem of delivery as well as consumption, that both sides of the equation are important. And that's a lot of the variability. It's not just the difference between a 24-weeker and a 45-year-old adult, but it's also between 24-weekers. A 24-weeker who's in septic shock has very different metabolic needs than one that's on bubble CPAP, for example, and that our measurements should be tuned to the needs of those individual patients as a whole. It's another level of heterogeneity to the population that needs to be accounted for. And then one other thing, and I realize it's a slightly different topic, but I wonder, when we're talking about sensor placement, whether it's a hemodynamic monitor or NIRS or any of these other things, if we can take some lessons from the EEG world, where the placement of sensors is extremely standardized. I mean, it's an international standard of these probes that are based on head circumference, and that there are certain landmarks that you aim for. If that could be used to provide more consistent performance, even with all these caveats we're talking about, but at least eliminate some of that variability. I think we all probably see regularly in our units electrodes of all sorts put in approximately the correct areas, and as long as there's QRS complexes going on the screen, then that's that's enough for most purposes, but adding that layer of precision.
I think also we should probably discuss the fact that if we added that layer of precision to T and echo measurements, or you know, obtaining the images, or where exactly we're measuring, like as a worldwide initiative, then we could also, you know, maybe standardize that and have a little bit more inter-rater reliability. Jean, go ahead with your comment.
It may be following on from something Patrick said, and maybe there's a bit of Irish nihilism in the whole discussion, but I think, you know, it's taken us 50 years, I think, to realize that blood pressure monitoring has problems. And I think the whole area of blood pressure monitoring has led to a very slow march in understanding hemodynamic monitoring of babies. I think there's been an over-reliance on it, and I think discussions like this are really, really beneficial. And I think Willem's you know, important flags around non-invasive monitoring. We need to be very, very careful before we start going around and managing babies with non-invasive monitors, cardiac output monitors that become standard in the intensive care unit, and then 20 years later we realize we don't know what we're doing. You know, so I think that that's a really important point. And on that note, in relation to what Valerie said, I think utilization of, and you know what, I know many centers do this, but I'm going to say it, utilization of somatic NIRS is nonsense at present. You know, I think it is incredibly problematic. I think people don't realize issues related to its use. And I think, you know, for the last 20 years, we've been looking at cerebral NIRS in a lot more detail, an awful lot more detail. And there's a trial that we're hopeful will be reporting in the next couple of months, which will, you know, give us some insight into the role of cerebral NIRS. And rather than embarking on incorporation, whatever in a research setting, but in a clinical setting, incorporating somatic NIRS into decision making, I think is very, very problematic. And of course, the biggest problem in all of this, if and to be very controversial, is that we, us clinicians, if we apply the criteria for a monitor, you know, as in the criteria that Willem has mentioned, and apply that to us as individuals, then accuracy, precision, keep going, you'll see such variability. And so it's problematic. So we do need to continue to strive to find objectivity, to try and answer these questions. But we are the most important monitor in the unit. We're the monitor that makes decisions. And, you know, I think we need to just think about when we make those decisions, what we're making them on.
I fully agree. And what I always find very remarkable is that if you ask the doctors during meetings like this, and well, who is only relying on blood pressure, and everyone, no one raises his or her hands. But if you visit the centers and you ask the nurses, they'll get a cutoff value of the blood pressure, and that's it. So in the real life practice, blood pressure is still the most used parameter. So there's a discrepancy between what we say we're doing and what we're actually doing and ordering and discuss with the nurses. Yeah. I'm sorry, that's not a very clear and, well, this is the way to go, but I think we should be aware of all the limitations and the caveats, and we have to work on it, and that's what we try to do, to find a way of a good way of hemodynamic monitoring, because it's important. But unfortunately, it's complex.
Yeah. I think there are limitations, obviously. I would tend to disagree with Jean's statement that somatic NIRS has no benefit at all, but I do think that you have to just take into account what are the limitations of each technology, and can the combined use of various types of technologies kind of lead us to a better answer. And maybe that's like with incorporating all these data streams and, you know, bringing in things like AI and machine learning, but I think there is a path forward, and it's just trying to find that pathway with what we have currently available.
Yeah, I think AI will be very helpful, but trash in will give trash out. So we have to be aware that what we put in, it's reliable. And I think that's a problem.
And Valerie, to follow up on your comment, and I fully agree with you. The problem is you understand these limitations, and the vast majority of people who buy these devices are who are approached by companies who buy these devices and are told X, Y, and Z don't know these limitations.
Yeah.
And I think that's one of the biggest challenges, I think. But also I do think that there's probably a lot more work to be done on somatic NIRS before it becomes something that is, combined in a algorithm to decide to use potential medication or not. I mean, I think we're a long way off, but I think groups like yours and Zach's and Willem's and Patrick's and everybody else's on this call are trying to actually, if you will, explore these and come up with potential algorithms down the road for people to make objective decisions around monitoring or around intervention.
One thing I was going to bring up that Willem, you mentioned in your talk, the importance of validation and how much of a challenge that is, because everything we're validating against has its own problems, and we can't take all of the babies to the cath lab to get a true comparison. So I'm curious what the group thinks about this. Instead of trying to validate technologies against other technologies with their flaws, is there a consistent outcome that we can use to define whether a measure is good, whether it's measuring something important or pathologic, do an outcomes driven rather than an input driven?
I find that very difficult to answer this question because I really don't know. I still believe that we first have to validate the devices, the systems against a good gold reference method. That can be either in the animal lab. I've tried it. It's not that easy. The bioimpedance to get a good signal is very difficult. So I was working on, because I validated transpulmonary ultrasound dilution is the co-status by Transonic. I've got no financial interest and no commercial relationship or whatever, but that was validated as a good objective way of measuring cardiac output. It's like the PICO in the pediatric intensive care unit. I was hopeful that I could use that one to validate the non-invasive cardiac output monitors, but unfortunately the disposables are not produced anymore since the COVID epidemic. So that is limiting our possibilities of having good validation study. I can't answer your question the other way around, but maybe I don't know how to do that. But maybe I don't understand it correctly, to be honest.
Willem, is the other way of looking. I think what Zach is getting to is, yes, it would be ideal to do a perfect study, which again is going to be reflective only of a certain state, which is the state at which you do that study, showing that trends or patterns are consistently associated with disease states. Okay. Is there not some value in that? So, these technologies are never going to tell you what's wrong. They're never going to tell you what to do. But we've all acknowledged that the mortal human is not good enough. We're not. There's too much variance. Can it help you say there might be something wrong? If we can do that, I think we've moved the needle.
Yeah, but I always refer to a very important study I learned from Shane Tibby, a pediatric intensivist from London. And he did a study and he evaluated the ability of clinicians to estimate cardiac output. So it was not in newborns, but in larger children on the pediatric intensive care unit. And they asked the clinicians, juniors, seniors, different level of experience, please tell me what's the cardiac output in a specific patient. And you can use everything you use on a regular basis. Blood pressure, urine output, central venous oxygen saturation, lactate concentration, blood gas analysis. Think about it, the conscious level of consciousness, etc. Everything that we do in our daily practice. Of course, it's very difficult to give an exact absolute value of the cardiac output, but they also asked, give me a classification of the cardiac output. Is it low? Is it low to normal? Is it normal to high or high? Only 25% of the patients in the deepest shock, and that was below 3 liters per square meter per minute, and that's really in pediatric intensive care is the real deepest shock, only 25% were categorized as such. So well, that was striking to me, because I thought the children deep in shock you would recognize. But even the experienced intensivists, they couldn't. And then you can say, okay, that's only one study. But Egan did the same in the pediatric intensive care unit, same results. 2 studies in the adult intensive care, the same results. We don't know it from the neonatal intensive care. And I do hope that our patients are an open book to us and that we can really see which one is in a shock or not. But I don't want to, I don't rely on that too much anymore. So I don't want to sound pessimistic, but and I do agree with you, we're not able with all our knowledge, with all our technologies, with all our clinical skills to really interpret that in the correct way. So I think that's why we should try to have the input and parameters should be right. If we measure it, we should be as accurate as possible. And we have to combine it and have to be comprehensive. And it can be helped with AI and all other kind of technologies. I think that's the way to move forward.
Thank
and
you.
discussions like this. Yeah.
This is a great discussion. I do want to be cognizant of everybody's time, and we are running just a little bit over. And so
we can go, Danielle, to 2:15. You've got 9 more minutes.
Oh, okay. I thought I was 2:05.
No, you're okay. You're fine.
Okay. So this was kind of an interesting question that popped up in the Q&A box. And then just to say really quick, I see a hand up in the attendings or the attendees list. If you could type your question into the Q&A, that would be the way that we would be able to get it. But what about looking in the cath lab and babies who are sedated, et cetera, and comparing the non-invasive cardiac output with, other monitors that we can do in there? Thoughts on that from any of you?
Of course, the cardiac output measurement using in the cath lab that is used as a reference method, and then you use the oxygen FIC method or the thermodilution method, different, and that's a good way to go, but it's rather invasive and well, it's not possible with many patients, so that's limited the possibilities you have, but that's a way that you could go to try to validate these technologies if you can use those non-invasive cardiac output devices in the cath lab. Sometimes it's not compatible. You should always be aware, can you use it in a specific environment?
Okay. Anything to add to that? Zach, do you have any experience with that?
I think that's right. That would be the gold standard. I do, with any of these measurements, the patient population that's going to the cath lab is not necessarily representative of the whole, and there's going to be a lower limit. I mean, it's tough to get anybody under a kilogram into the cath lab, so that's you're still kind of operating in the dark under that size. And then most or all of them are either heavily sedated or under general anesthesia, which is going to add its own impact on hemodynamics. That may or may not be true, but I agree, it's the most controlled environment that we have for validation.
And so just a question kind of stemming from the question that's here. So they're saying about looking at SpO2 monitoring in your limbs versus your forehead, and if there might be any differences. And I think we have some with NIRS monitoring of, we see that there are differences between like somatic NIRS and your cerebral NIRS with those. And really another question is, how many of you, at least early on for hemodynamic monitoring in your newborns, rely more on the right hand or preductal saturation? Any comments on that? Valerie, do you want to try to take that first, since you have experience with your NIRS?
Yeah, I'm reading the question, and I think a limb, so that's more of like a peripheral measurement, like a muscle NIRS reading, compared to a sensor on the forehead, which would be more like directly like a brain cerebral tissue oxygenation, which we know can be very different based on perfusion issues, especially. I think we all have issues when we put on a pulse oximeter, and if baby is poorly perfused, that's not picking up at all because we don't have the pulsatile blood flow. And that is one of the benefits of using NIRS, because it doesn't have to rely on pulsatile blood flow. So I think it's interesting to consider the differences there. I think our group is more familiar with using as a somatic location the renal NIRS probe, just because it's more of a direct reflection of what the descending aorta flow is seeing. I don't have as much experience with like a peripheral site, and maybe others in this group can speak to that a little bit more.
Well, I did see the question whether or not it would be possible to measure the oxygen saturation on the forehead. I know there is a possibility of measuring the heart rate using a sensor in a specific hat, and that firm is also working on a oxygen saturation. So you can put on the hat, and on the forehead it will give you the heart rate and the oxygen saturation. And we're currently validating the heart rate against the regular ECG, but we don't know already about the oxygen saturation.
And then another just question, how many of you, or do any of you have, portable MRI scanners? Because what we've mentioned is the MRI, cardiac MRI being kind of the gold standard. Is that something that's put into practice in any of your units for cardiac output, ventricular contractility function, those kinds of things?
Well, in my perspective, it's only a research tool and not for clinical application, because it's not practical, not possible to have the baby that's most in need of cardiac output measurements and hemodynamic evaluation. You can't put that very easy in a cardiac MRI. There are some MRI compatible incubators if the baby isn't that one and you have a MRI on the ward, but that's really very rare, and I don't think that's feasible and very practical in daily routine care.
And I think, correct me if I'm wrong, I think most of the field strengths of the portable magnets are less than 1 Tesla. And I don't know that they have the ability to do gated sequences either. So technically, I don't know that it's even possible.
It is. I had some discussion with some vendors. You can do it, but it's not practical.
Right.
We have no experience with MRI in our neonatal service. Can I go back to the NIRS question, I guess, in relation to the muscle side of it? I mean, there has been work done in the past by Michael Weindling and I think Gerard Pichler a number of years back with venous occlusion, but they are just intermittent measures, if you will, of muscle perfusion, as opposed to it being, I mean, if you think I'm nihilistic about putting it on the kidney or the liver or wherever, I think putting it on your forearm and leaving it there is probably, I don't think it's going to add very much. There are devices coming down the road, new devices are being developed. We do some work with a photonics center here who are looking at a different type of technology around saturation monitoring. So there may be in time devices that sit on the forehead that do give you a readout of the actual SpO2, but they are based, I think, on time of flight technology. So I think it's another number of years before that would be available.
Valerie, anything to add?
I was just thinking back to the question about going to the cath lab, and I think it lends itself well to specific populations, like, for example, those that are getting their PDAs closed with cath closure. That might be an interesting group to look at, the cath measurements with non-invasive cardiac output, just to kind of get those correlations.
Yeah, although I do think if you want to have a cardiac output measurement in the cath lab, you need dedicated catheters, and that is not what you need for a transcatheter closure of the duct. So will you have some additional interventions? And I'm not sure whether that will be safe and feasible and possible.
Right. And so as we're coming up to the time, any last comments from our panelists or our speaker? I think this was a great discussion, very valuable for all of our attendees.
Thank you, Danielle, for coming off the bench.
Subbing in at the last minute. Thank you to Dr. de Boode and to all of our panelists. Thanks to all of the attendees. I do hope that everybody got as much out of it as I did. This was such a fantastic talk and discussion.
Thank you. I enjoyed
Have a wonderful holiday, everybody. Safe travel. Keep safe.
Thank you.
Thanks, everyone. Take care.